Welcome to the Coronavirus Pandemic and Clinical Practice Post-Crisis, presented by Dr. El-Char. Dr. El-Char has two more sessions coming up that I'd just like to highlight briefly. This Thursday, the 23rd at 11 a.m. EST, he will be presenting current concepts in bone regeneration. Next Tuesday, the 28th at 11 Eastern Time, he'll be presenting complications in implant dentistry. You can learn more about these upcoming lectures and register at straumann.us-webinars or straumann.ca-webinars. The CE for this course will be available in your skill account 24 hours after the events take place. Dr. El-Char completed his doctorate of dental surgery, his postgraduate education in advanced periodontics and dental implants, and received a master in oral biology, all from New York University. He is a diplomat of the American Board of Periodontology and Implant Dentistry, member and fellow of the ITI, and member of the American Academy of Periodontology and Academy of Osseointegration. He is currently a clinical associate professor at the Department of Periodontics and Implant Dentistry and the director of Advanced Education Program in Periodontics at NYU College of Dentistry. He's the former director and founder of Advanced Education Program in Periodontics at Lutheran Medical Center. He has a thriving private practice in New York City that specializes in dental implants and periodontal disease. I'll now hand the presentation over to you, Dr. El-Char.
Thank you, and good morning, everybody. It's a different times, and we are talking virtual these days, and I want to really thank Straumann. They've been pioneer when they had the Academy of Osseointegration virtual corporate forum. They turned it into virtual instead of shutting it down, and they've been very active in giving a lot of lectures and a lot of CEs for all of us. So really, I want to thank them for this and for this opportunity to push me to do this subject that is really important for all of us. Coronavirus has changed our lives overnight. We've been thriving, and all of a sudden we are at home and scared, and we don't know what is going to come out. And so I hope by the end of this, we will be able to remove some of the myth and we get more into the real things and how we can move forward with it. It's actually striking. I never thought I would be talking about that, but when I was 19 in the 80s, I was in the first dental school year, and we had the AIDS epidemic at that time. And if anybody of you that watching were in the 80s as a dentist, we remember that the gloves were not available. We didn't wear gloves, and how things have changed overnight. And now we are reliving it again. And I never thought I would be talking about this, but here we are. And so let's talk about it more. So, okay, I'm sorry. Yeah. So this is the virus. It's a very beautiful virus. It is interesting because it's an RNA and it is cleaned up by soap and you can remove it. So it's not that difficult to clean it out, but it is very contagious, and that's how we have been told. It's a respiratory infectious disease that is highly contagious with a high mortality rate that transmits from aerosols, droplets, and saliva. The question is it really a high mortality rate as we thought? And is it that contagious as we think? And that's what we have to learn over time. But to put things in perspective, allow me to take you back into something similar, which is the flu season. And this is what you see on the CDC. And I want to focus on the 2017-2018, because you can see there is thresholds that goes up, because that's how it works with the flu. So if we look at it at the CDC and we focus on 2017 and 2018, we're going to see the numbers. The numbers are striking. It's 50,000. Sometimes over that. But the interesting thing, it goes over 40 weeks of time. Now, if we move forward with coronavirus and we look at the Johns Hopkins website that keeps track of everything, from the 700 or 750,000 people that have been confirmed, as of yesterday, we have 35,000. Before we started, they just sent a notification that this is the first time we have the lowest rate of death recorded. So something is happening. So if we look at what happened in comparison with the flu, look at the difference. The other one goes over 40 weeks. This one hits us hit us in 4 weeks. And that's why it has been so scary for a lot of people. But if we look at New York City itself, and we look at the cases that have been confirmed and the amount of total death, it's interesting to see the new curve that they just put yesterday with the new cases. We can see that there has been a huge drop in the new confirmed cases. That is a very, very good sign. So if we go back also on the predictions, this is the bell that we can look at it, and we can see that this is why we have a 2 months usually from the beginning to the end of it. And that's why you can see the governors of the East Coast of United States, they started talking about reopening in May 15, because by then they are hoping that the virus we will see the asymptomatic will be purged out and things can go back to normal. The question, is it going to be back to normal like a switch that we turn it on and turn it off? Well, let's go back into virology. And scientists use the term R0 to measure the reproduction number. And that comes from the 50s when a very famous epidemiologist, George MacDonald, and he was working on the malaria at that time, was the biggest pandemic. And he said that in order for this to become livable, it has to go less than 1. But if we look at the influenza, the flu seasons, it is actually 2 to 3 of an RO. Compared to the measles, it's 15, it's much lesser. But the influenza happens every year and it persists because it mutates. So we don't know if the coronavirus is going to mutate, but so far it's not. But we have adapted to it because it's repetitively exposing us to it. So that's why we can continue with our life with it. So the only time that we have any kind of recording was through a webinar that was done at the University of Washington. And I want to thank Dean Glenn Morris from NYU, who had given me this resource and helped me quite a bit on this. And you can look at it that the rate is 1.4 to 3.9. Is this rate correct? We don't know yet. And let's see why. Well, there is difficulties with this virus and numbers of them. First of all, the infectious period. We don't know when it will infect us. So, or when we can be infecting the others. Like we know the flu, if you have the symptoms, you are immediately infectious. With this one, we don't know. Some people get tested with the swab in the nose. They were negative at the first, second day, then they thought they were exposed, and at 7 days, they get positive. So that is one of the biggest issues. Secondly, there's a lot of mild cases and cases that they are asymptomatic. So we haven't had enough surveillance, like they call it. Thirdly, we don't know how it is going to be susceptible within the new population that it penetrates. So that's something also we have to learn throughout the time. And fourthly and finally, we don't know the effect of what we've been going through, the self-quarantine, the social distancing, the travel restrictions on the RO of that virus. So if we look at what the CDC had predicted, they were right. 25%, even 50% of people are asymptomatic. And that is the biggest problem with this virus. Just today morning, when I woke up, I saw this news flash, and A Times has published a precursor of a study that has been conducted right now in LA County, but by USC. They've tested 863 people, and they did the antigen or antibody study on them. And they found that it's 28 to 55 times higher than the reported cases, because the reported cases were people with symptoms. So now we are looking at almost 400,000 people, they have no symptoms. So that will lead us to reduce the fatality rate. So there's a lot of fear that has been pushed on us, but in reality, this virus has been with us and we have not knew about it until towards the end. So what have we learned today? I mean, or what are the guidelines and why we have these guidelines? So if we look at the task force, they said that you have to be 6 feet. I like this picture. We've seen it all the time in physics, and you know it's appropriate for this time. The 6 feet is something that we have to live with. Secondly is the hand washing. And you will be shocked that There is a study that I found by Wolf and al. In 2019. 51% of the developed world are not washing their hands after going to the bathrooms. Only 22% in underdeveloped countries where they have less exposure to hand washing. This is huge, and that's why we have spread of diseases in any time with the flu or anything. This is because of the lack of hygiene. Also, we've been told to stay home, and stay-at-home orders has been implemented, and we don't know when they will be lifted. Some places they're saying by May 15, like we are in New York. And we've been told to face covers when we don't have access to face covers. I mean, also a lot of things that have been pushed on us because of act of fear and action. And we've been asked to shop online, but we are in dentistry and we cannot do things online. We cannot do treatment online, and that's another big problem. And that will lead me to this. The question is to be asked, how will this affect our dental practices post-crisis? Well, if we look at the most recent study that came from China, and it was published recently in the Journal of Dental Research, which is one of the highest journal to be published in. And they found that definitely it is due to the droplets and aerosols in our environment. And also the lack of knowledge on the incubation period, which we've discussed earlier. So if we look at the interim guidance of the ADA, you can notice that they are all focused on aerosols, aerosols, aerosols. What are we doing that we use aerosols? And that's based on that, you have to take into consideration what kind of protection you will need, which we will discuss throughout this webinar. The cross-contamination. This is something that's been with us for a long time. It's in 2012, there was a paper talking about it, and they said that the cross-contamination is underreported. It's the same thing that this study that came from China talked about it, the same story. So again, cross-contamination in the world of dentistry. So, sorry. Recently, the president of the ADA, Dr. Shad Jahani, said the longer the dental practices remain closed to preventive care at treatment for early forms of dental disease, the more likely that patients' untreated disease will progress and increasing the complexity and cost for treatment down the road. I cannot emphasize how important what he said. We are in the healthcare and those patients need treatment. So let's talk about us as the periodontist. We do a periodontal maintenance every 3 months. So the patient that they needed to be seen by early March, now we are throwing them up to June. And that's going to create more problems. And also people being at home, as we know from experience in private practice, if they were going on vacation, their oral hygiene decreases, they are delinquent, they are depressed, those things are going to increase. So the work in dentistry is only going to increase, but the problem is not going to increase in the right way. So this is what brings us to this chart. This is what they are saying, May 15. Is this right for us to stay till May 15, or we should start preparing ourselves to start by May 1st? Because if we look at the data of yesterday, things are evolving very fast. We are going to stay closed as a country. We're not going to communicate with the world, but we need to move on with our own lives. And this is why we need to be prepared. And what I want to talk to you about is the healthcare providers' protection, and that is very important. And finally, how we can integrate digital dentistry from communication and planning and treating to be able to survive with the incoming era that we're going to be living in. So if we look at the healthcare providers' protection, there is nothing new in it. It's been always written between us and around us. The problem is we never paid that much attention to it. So if we look at the new guidance from OSHA, and in it, they have classified the different professions by risk of exposure. And as you can imagine, we as dentists, we are on the highest risk. And not only us, the dentists, but also the laboratory personnel. So anybody who takes an impression, receives the impression, they are on a high risk as well. And I want to thank my hygienist, Patricia. She sent me this beautiful chart. And if you look at it, the dental hygienists are at 99.7% of risk of exposure. The dental assistant, 92.5, and the dentist, the generalist, or all of us, we are at 92.1. So from that perspective, what did CDC give us? This was in 2016, which was an upgrade of the 2004. And in 2016, they replicated exactly what we are talking every day and every second of it. Perform hand hygiene, wear protective clothing, wear mouth, nose, and eye protection, remove PPE before leaving the work area. Nothing new with that. If we look at the 2004, and in 2004, there was an uptick with the tuberculosis. So then they started talking about masks and respirators. And now it is the talk of the day in our field. So what are the masks? Well, we have the N95, and we will talk about what is the N95. And this is something that can be worn in an infectious tuberculosis. And we know that tuberculosis is highly contagious. And if we are doing, or at least medically, they are doing a bronchoscopy, which can lead to droplets or aerosols, this will lead to be used with powered air purifying respirators. What are those two? Well, this is what the N95 look like. Now, we've heard a lot about it, and I'm sure because we're sitting home, all of us reading about it. There is what it means is 95% of the filtration is achieved. And this is also certified by the Occupational Safety and Health Institute. But also, we're going to see a lot of other ones that they are coming into the States without the FDA approval. We have the likes of the K95, which is used in China, or what is used in the European Confederate. You have the FFP2. In Korea, it's called Korea First Class, and in Japan, DSFFR. And the differences between them is very minuscule. Like you can see in the European one, it's 94% instead of 95. The Korean, the Chinese, and the Japanese is within 95%, similar to the one in the United States. But you can see now there is tons of them, the KN95 available in the market. And you can imagine how much they're making fortune out of it now, selling them more than they should be selling them normally. The respirators, thank God we are not going to be using that, but just for you to know that this exists and what they are, and we're going to see, it purifies the air. So they have these filters on the back of them here, and they are filtering the air that we are breathing. If you are claustrophobic, that is not something like myself, it's not something you look forward to, but that's what exists, and that's something that we also hopefully and never use it in our practices. So let's go back to the OSHA and what the OSHA has told us. Well, in this new that came out in March, it talked about the safe work practices. And in the safe work practices, they have asked us to be avoiding cohorting employees and patients. And that is very important. Secondly is, how can we do that? So I'm going to give you a small lay of the land of my practice. This is how our waiting room looks like. And in this, you can see in a normal time, we have 3 on the front desk. We have water bottles, we have pen, we have plants, we have magazines. That's something that should disappear. And thirdly, in a good day, we have 7 people. Can we have all of this post-corona pandemic? Absolutely not. So what are we going to be doing? So we have to limit the amount of people that come in. We are going to limit also probably the amount of the front desk or alternate them. We are definitely eliminating all kinds of things that can be touched by other people. So how does the waiting room will look like? And that's to give you a snapshot about it. So you have to cover everything. You have to create a minimum amount of people walking in, and you have to have the room bare from all kinds of things that the patient can touch. Even the pictures on the wall, I don't know if we need to keep them or not. And also that brings us also on the entrance. Now we are in New York City, we are in small confined spaces. We have to create a social distancing between the people sitting one side to another. And also you're gonna see, we'll talk about it, how we have secured our front desk. The screening protocol, that is extremely important. We can't take it lightly. Anybody that is gonna come, you're gonna call them the day before and the day that they come in, and you're gonna go through the same thing. We have to check for the fever. We have to check for the cough, sore throat, shortness of breath, any flu-like symptoms. And this is gonna be part of us. Now, I don't recommend the one that you put it with the ear. There is the new ones that you can pass them in front of the forehead that can scan. This way we'll avoid contact with patients. Secondly, we have to provide alcohol-based hand rubs, and that's going to be all over your office, and good luck finding them nowadays. They're becoming a luxury. And things to consider. First of all, area of staff to change and store their clothes because they're going to walk from outside inside. Thirdly, the kitchen and rest area that they used to have and eat in them, you can have to avoid aggregating them and avoid the distance. It creates distancing between them. And thirdly, you need to create an area where you can dispose of the PPEs and the masks. So these are the things that we need to consider on top of what I showed you with the waiting room. Thirdly, that is very important, and this is going to be probably a mandate, is the engineering controls. What does it mean? Well, we have to look at how we can filter the air. Now, I have spent quite a bit of time, like I'm sure all of you, about looking how we're going to filter the air. There is tons of things out there, but the reality, you have to look for something that's going to create a real filtering of the air. And I found this machine. It's made in Canada. It's surgically clean air, and I ordered them, and you have to see it's a wait to get them and available, so you need to jump on the queue. The queue is getting longer. And lastly is installing physical barrier, such as clear plastics to cover the front desk. And this is how they look like. They are a clear plastics. Now you go to Target or any place, you're gonna see them. This is something that is gonna be mandatory to have on our front desk because they are the front line of our offices. And that's exactly what we did in our office. You can see we have installed them, and even the front desk is gonna be wearing what we're gonna call it, the protection gears. We're gonna look at them in a few seconds. So the question is, do we really need to wear N95 all the time? Well, no. That's what was answered in University of Washington. It is only if the patients are screened negative, they don't need to be treated differently. And definitely we're gonna wear level 3 masks or doubling the level 1 if you cannot find the level 3. And we definitely have to put a face shield. And then definitely I encourage you to put also, if you don't wear loops, to put a eye cover under the shield. So this is how we're going to be practicing. And that's something that we had over the years, but a lot of us never done it. And I can tell you, you know, I'm from being at NYU, and we see 300,000 patients and tremendous amount of students. Even to implement this between our students, it was difficult, even with our staff and everybody. And things about taking a coffee in the operatory room or treatment room, this is something that we cannot do anymore, and we shouldn't have done. So all of these things were existent, but we have never implemented it rigorously. So what are the ADA interim guidance for the management? So first of all, it starts by you need to make the patient rinse. And we don't know if these rinses are going to work, which is hydrogen peroxide and even povidone, iodine. I don't know how you're going to make somebody rinse with iodine. But nevertheless, what I would suggest for you is that you make them rinse for at least 1 minute with hydrogen peroxide and swab the face with iodine before you do any treatment on them. This is something we do for surgery all the time. Use extraoral radiographs, so panoramics and CBCT. Imagine how this is going to be. This is going to be huge for us because also there is the risk of exposing the patient to a lot of radiations. And the reason behind it, it's all based on studies that have been done, the MEG, the one from China, and the one in 2004 also from China. And these were during the pandemics of also the SARS. So that creates the intraoral, creates and stimulates secretion and coughing. So for people who gag, reducing aerosols, and even trying to do hand instrumentation. That you can do it in periodontal maintenances, in root planing and scaling, but how can you do it with removing cavities? And that's why we need still the high speed. Using rubber dams, this is very common in endo, but not common in restorative. Some people do it, some people don't. Using the four-handed dentistry, it is very recommended, and this is also by the new publication from Meng. And also, we need to have a high volume evacuators. And what it does, the DHCP is the dental healthcare provider, they have to use it because the saliva ejector can create a backflow, and the backflow will create a cross-contamination. So that's something that we need to adjust to it. And also the sutures, like us, we do surgeries, we have to use resorbable sutures. And lastly, the air syringe that we have, we need to avoid using them at this time. And I don't know what's going to happen in the future. So what are the high suction vacuums? And you can see this is a new thing. I got acquainted with it and I ordered it for my practice, and just give you a video about it that they just made it yesterday in the US last night, and they gave it to me. And this is how it works. Now, definitely you have to be wearing gown and face shield, but look how the aerosols are suctioned out from the mouth on top of the high vacuum that you will put it in the mouth. So that brings us also to another question that has been raised in that webinar of University of Washington. Are we going to put nets over our hair? It is wise to do it. I highly recommend it. We are going to be doing it in our practice. So we're going to be looking like this for the time being and probably for the long term. And that's going to be even helping us in protecting ourselves and protecting our patient. Don't forget, the hair is a big collector of bacteria and viruses. And that brings us to the PPE. We don't need to wear a full-bodied gowns unless you are with somebody on a high risk. Definitely the disposable PPEs. And I'm gonna take opportunity and show you a picture of me before the pandemic. And definitely this is not gonna happen anymore. Definitely I'm gonna be wearing the PPEs, but I'm not gonna be wearing a tie and a shirt anymore. And I'm gonna have a side shield or the face shield. The problem is if you have loops, and this is what is happening. Now I use the Designs for Vision, and I'm very friend with the owner. He's a patient and he's a dear friend. And that's his number 2 in the corporation. They just did them and they just sent me a prototype of it. So we're gonna see all the other company, Orascope and all, they are gonna start, or they have already face shields that you need to look for that. Because for me, without a face, without loops, I can't practice properly. The most important question that is still interesting is how long does this virus survive on different surfaces? Well, you're going to see that it lingers, it doesn't go away. And you can see it on cardboard 24 hours, on paper 5 days, on ceramic 5 days. The only one that goes fast is the copper within 4 hours. And I'm sure you heard about it, that they are trying to do some filters with the copper. That brings us to this, and this is very important. We have to disinfect thoroughly between patients. It's not like before, 5 seconds and 2 minutes. We have to really thoroughly clean the rooms and space the patients, meaning if you're having hygiene, you have to give the hygienist at least 10 minutes between cleaning the room, changing the air in the room before you bring new patients, and for them to change their PPEs. And this has also been noted in the CDC, and they have also recommended which are the disinfectant. I've put for you all the website, and I have all the resources piled up at the end. If you are interested in having them, either I can send them to Stroman or you can email me. I'm going to give you all my contact at the end. The question is, don't panic. And that's where it's becoming a problem. Everybody is panicky. I had a Zoom meeting with my staff yesterday, as I'm sure you are doing it. And they're all panicked of coming back, especially anybody who is end of 50s and early 60s. They are panicking because the news that we are surrounded, that we are going to die if we're going to get this. And this is why we are learning more and more. But in reality, we have to stop the panic because life has to go back to normal and we have to continue as we were. So that brings me to a more interesting part. It's something that we deal with all the time, and that will be the end of our presentation, talking about digital dentistry and how we're going to move to that next level. So we covered all the infections, all the preparations that we need, but there is a big part of it is how we treat the patients and how we communicate with the patients. I'm sure that we know it, and I've mentioned it in the webinar that we did in the corporate of AO. If you have attended it, the question is, what is digital dentistry? Digital dentistry is everything that is images. It can start with the digital radiograph, to the digital photography, to the CBCT, to the intraoral scanners. Also, we have the printers, the 3D printers, the millers, and we cannot forget what we got used to is the Zoom. This is a meeting we had. You can see how we're looking with our staff, but I'm sure you are all doing it together. So that brings us to this reference actually that was published in 2019 about teledentistry and how this teledentistry or all the digital world is disruptive for us. Well, teledentistry, I have my reservation about it. I'm sure you all had text messages from your patients showing you this tooth and covering like this and taking a picture. How can you be able to diagnose through a picture? So this is something that it cannot happen to us because we are people that we are physically involved with patients. We cannot be doing it from tele away or from virtually. Now, my niece, she's an endocrinologist. She's been working telemedicine. But again, even her, she's telling me that I have diabetes patients. They need to have checkups. We have to do their vitals. We have to take their blood and on and on and on and on. So again, how much this will be really reproducible, especially in dentistry. Disruptive, it's not. I don't know why we are afraid of this kind of communication. We have to espouse them because the Zoom communication did not come yesterday. This is something, I'm a retired major in the US Army and I'm very proud of my service. But in the 2012 and even before, there was a General McChrystal, one of the best generals we've ever had. He introduced this communication, virtual communication, because you can imagine he is in one spot and every other soldiers all over the world. So this has been happening. It is nothing new. We are new to it. In every industry, they do it. So this is something that we need to espouse and be open to it. And I'm going to show you how. For instance, this is a patient that came to me before this pandemic, and we were supposed to treat her. She came because of this complication that she had. We will talk about it next week. But how am I going? And that's what I've been doing all along with my referrals as well as with my patients. So what I do is I take pictures. As soon as the patient walks in, I take pictures. Now, definitely there is a lot of platforms. There is the Coachman platform. There is multiple platforms, but I created my own platforms. It's easy. If you are good in PowerPoint or Keynote, and if you're not, just get used to them. They're very easy to be done. So you take pictures. You take the one before the smile, one in repose, one with a smile, then one intraoral. I take side pictures. And now I start planning the case. And I start placing where my gingival zenith should be. I measure my teeth if they're the height that it should be. And then I put my teeth. This is, you don't need to buy anything. You can do them with Keynote. You can, there is a drawer, you can use it and you can draw the pen, you can draw the whole thing, and then you can place the teeth. And now you can also draw the soft tissue. And this is, you're preparing your case and you can do it from both sides. And now you can plan it. And now instead of bringing back the patient and increasing the footprint in your practice during this time, all you have to do is go on Zoom and then you can show it to them. And also you can communicate with your referral. If you are a periodontist, you can do the same thing. You can go on Zoom, you can share your screen and you can show it to them, and then you can go over the case and you don't have to visit each other and be face-to-face until this part will go through and hopefully a vaccine will happen. And that brings me to the last part, the planning and the treating. And this is something that is very dear to me because I've been doing for a long time and I've immersed myself in it. So let's look about the conventional impressions. And just to tell you a small summary, there is only less than 9% of the dentists in the United States, I can only talk about the United States, that they have been involved in digital dentistry. We all love our impressions. The question is the studies on the impressions and the cleansability of the impressions all date from the time of the AIDS epidemic. If you see here, Bergman in 1989, he said that every patient has to be a high risk. Look at it, 1989. Most importantly is what had happened since. This is a study that done in 2008. They checked about the contamination of the impressions and the gypsum casts. And if you look at it, what they found is that they have a huge amount of Candida, MRSA, P. aeruginosa, that they are non-pathogen for cross-contamination. The nosocomial is the term used for cross-contamination in an environment of a medical environment. And the same thing that this gentleman from China just published about it again. So thirdly, there is another study done in the British Dental Journal in 2010. And here they found that they did a survey and they found that only the lab technicians are confident that 64% of the dentists are cleaning their impressions. And if 15% of the time they have a blood filled when they were trimming the cast, and 91% of them had received blood contaminated impressions. So that will lead us to that we need to be more vigilant in disinfecting. That brings me again to that slide that I showed you. All of these then done not on the impressions because nobody is talking about dentistry right now, but this is all exists. The knob that we touch, it lasts on it 5 days. So we don't know about the impression material. And this is what I took, I didn't want to take it from patients, but I took it from the internet and you can see this is what we do. The other risk with impression is what? The gagging. I'm a big gagger. I hate having an impression done on me. Thank God I don't need it, but just in case, you gag. And by gagging, you have to be spitting and saliva and coughing and all the good stuff that can bring the aerosol into the environment. Rather than taking a camera and going inside the mouth and scanning the whole mouth. This is something that is going to be with us. And this is something that if you haven't been involved in it, you should think about it very seriously nowadays. Now, I love that picture of this guy because it looks cool, but that's in reality, they're not like this. People with beard are going to have a problem because fitting the N95, if you need them, or Mask 3 on bearded people, it's going to be a problem. Cleaning the beard is going to be a big problem. And definitely you have to be covered on you and you cannot have a forearms that they are exposed. So that's the beauty of it. So you're going to get an impression and you're going to have the occlusion over it. And also you can have this STL, and that STL file going to be leading to a crown. All you have to do is email it. So there's no more people coming, taking, and all of these things. So in our practice, we've been involved in digital dentistry for a long time. Mainly I do surgery, but you can see that you can do a lot of things. We don't print any more stone for at least 4 years now, if not longer. You can have them like this. This is a model that I just took pictures for it for the occasion. And you can see you can do also from it deprogrammers, suck downs. You can use it regularly like the stone model. But just you have to have the decision to move forward with it. And definitely, if you have worked with digital dentistry, you can see these models that the lab can print for you and send them to you. They are exactly normal like we do in regular dentistry, which will move me now to how can we use it, especially for me in surgery. So in surgery, I got involved in it a long time. Definitely thanks to when you are in education, you are lucky because you have young people and they are very into technologies. But before I met this gentleman who graduated now, Dr. Ortula, I had one patient that knew that I love technologies, and they gave me this as a gift, as a 3D printed bust of I think, Ferdinand the Great. And if what we did is we evolved it over time and we became very efficient with it. And you can see, you can go for a software like Straumann has, the code diagnostic. You can look at the rendering of the patient. You can see exactly how the defect is, and you can print it and you can have it in your hand. Now, look how good this is. Now you can show it to the patient. You can increase your communication. You can show it even if you are like me, work with referral. I can show it to my referral and say, look, Dr. Smith, look how difficult this is. It's a big problem. We need to do this and this and that. This way, when the patients go back to their dentist and they want to communicate with them, they know exactly that we are on the same page and that the referral dentist is very well informed. We even move it further. We can take the tooth out and we can print it. And by printing that tooth, you can also put it back where the site is deficient. And you can see, you can show the patient and you can show also the referral or yourself if you do both, the amount of deficiency. In this case, look at this concavity that you have and how the tooth is up and down. That means you have to really do a good buildup of the bone. So when you retract that tooth, you can see that you need it in this case to build also the lingual, not only the buccal as we are all used to do. And sure enough, you can template it and you can make a titanium mesh. And this is something that I'm very, I've been doing it for over 10 years now. And we have a publication that came in 2019 talking about 100% allograft and the good results that we are getting from it. Moving along, let me walk you through a couple of cases that will make it a little bit more animated than only talking about coronavirus. So this is a patient that presented with a fractured premolar number 13. And if we were looking to place an immediate implant, then if you want to place it, it's going to be coming awkward with the restorative one if you want to follow the socket the way it is. So we have to go 3 to 4 millimeter past the apex, and we're going to exit in a very awkward way to restore it off X. So in reality, we need to place that implant in the right position, and we have to pass over the apex 3 to 4. And this way you can see the access of the crown is going to be more amenable for a good restoration. And also you can see the distancing, like the social distancing. We have the distancing in dentistry that also we can verify it before we move forward. And now we can take the impression. This is the STL model. We can take it to a software that is online. You don't have to pay anything. You can cut off that crown and it will become like this for you. And then you can even make your socket. You can use the tools of it to make it deeper and make it more of a socket. And now you have a model. It's on STL. You can export it. And this is how it looks like. And now you can take it to your planning software. And even you can print it. You don't have to print it, but at the beginning, when I was verifying everything, I used to print the models. But you can have the models, same thing as I showed you before with the 3D printer. And you can look at it from all sides. And then we go for the planning. And this is a wonderful software that they have, the code diagnostic, and you can plan your implant and you have to clean all the scatter that we have. And then from there, you just go through the steps. Place the impression, the one that is removed, then you place all the distances that you need, that you verify on it, put your sleeve, and then print your model and print your surgical guide. And when you have your surgical guide, you go to execution and it gives you a platform. Here I did it a pilot guided. And you have your guide, and then the guide, you can put it even and you try it over your model. Everything is fitting, it should fit. This is the beauty of the digital. And then you place your implant and exactly how you planned it. And from there, you can even prepare for the temporary, you mill it, and then you can connect it. Here we connected it in the mouth. And sure enough, we went for 4 months, and then we went for the final. So this is how it can give you the accuracy that we need. Secondly, this is an extracted tooth that is broken down, fractured. So again, to do the same thing, go to Mesh Mixer, extract the tooth on it, bring the model, include it in your on your code diagnostic, place your implant, place your sleeve, manufacture the guide, And sure enough, we hemisect the tooth and we have a nice socket. We do it all fully guided. And by doing fully guided, now you can fill in the gaps with the allograft. And now we can share it with CARES. There's another software where it allows us to do a healing abutment. This is all within the family of the Straumann. And then from there, you can mill it or you can print it. This is how we did it. We printed it and we connected it into mouth. And at the end, I'm going to show you a case where we can do everything outside of the mouth and we just go and execute it into the mouth. And this is how we put it. We waited 4 months and then we placed the implant, the patient on a temporary, and we were planning to do the final, but this happened. And sure enough, this is the last case. And this is, I've done it with one of my PGY3 resident, Dr. Amit Amin, who will be graduating soon. And I'm very proud of each one of them. This is a case that was built, the site was built. I'm going to show you cases similar to it on a Thursday, but that's not the time today. I want to show you the digital workflow. Now we have it all printed. All we had to do is take an intraoral scan, and from there we have put it over the co-diagnostic. And when we have it over the co-diagnostic, now we went and we extracted the tooth adjacent to it. So now we have number 8, and now we've mirrored it through the mesh mixer. And then we just imported it back, and we have a tooth that is inside the model that we are dealing with. Now we place an implant, we design the implant, we design the guide, and from there, all we have to do is go to the CARE software. We call it the case exchange, and from there you can plan the temporary, but digitally you can print. Also, you can see that tissue that you can also print, and you have them all prepared, and you can have a model with the lab analog of the exact position. Now in the execution, you can see it when you printed it. You can also try the guide over it to make sure everything is fitting. And now from there on, you can print the tooth. And the tooth, you will see why is it important, because you're gonna make a crown. And you can cut off that root, you can fit them in the mouth. You have the soft tissue that is prepared already, and all you have to do, go for the surgery, and you follow the protocol of the guided surgery of Straumann. This is the punching of the soft tissue. And then you go ahead and you put the guide and you do the 3 steps. This is a 4.1, so we do 3 steps, 3 keys. This is what we call the key. This is the sleeve, and that's the burr that the protocol will give you the length to use. And then we do fully guided. Here you cannot do a pilot guide. You have to do a fully guided. And once you have it fully guided, then you will insert the temporary that you made, and you're gonna take it out of occlusion. And you can see the accuracy of the positioning, even that it is screw retained smack in the middle of the cingulum. And this is a comparative, and that is the radiograph. So with that, I am at my time to finish. So in conclusion, dental healthcare providers are in a high risk. Not only that, we need to adjust and equip our offices with difficulties to get the needed equipment, especially now we can't find a lot of things. Economically, we will face a financial hardship, and I want you to pay attention to that. Other than the equipment and the material, we are gonna have a slow recovery because patients are not gonna be running. Even the staff is not gonna be running, coming back. And also, a lot of dentists, majority of the dentists furloughed all their employees, and they are getting a high unemployment pay. So these are all things that you have to take into consideration. And as you see, the SBA loan is not going to be for us. You know, you can see a university like Harvard, one of the richest universities in the world, took millions of dollars. I don't know why. So this is questions to be asked. But on a positive note, today we know that it's not that deadly as we have thought. We know that it's not that different than the flu, although it is contagious, but you have to always put things in perspective. We are going to learn more and more about it. But the most important is that we are going to come back. We're going to come back better prepared, and we're going to practice in a cleaner environment, and we're going to be even better than we started. And I am so confident about it, but we all need to be also positive. We need to give a positive answers to the patients. We're going to be ready for them. We are healthcare providers. We cannot leave our patient without treatment. It is not the end of the world. We need to go over our fears. And if we follow exactly what I have shared with you, we're going to be good, and we're going to be better, and we're going to be stronger. And with this, I want to end with, I call it the Sha'arisms. To live is to change, and to be perfect is to have changed often. And sure enough, a lot of you have practiced along, or they are new at the beginning. As I know, I see them all every year that we graduate them, and I'm so proud of them, that they're going to be at the beginning of the journey, or people like me at the middle of the journey, or some people at the end of the journey. But we have seen a lot of things, and we have to learn to adjust. And that's another experience that we're going to adjust to it, nothing more than that. So on this, I want to end up the presentation, and it's going to be open for questions. And if you want to reach me, this is my email. And if you want to follow us on Instagram, you know, this is the addresses, and you can always be posted, keep you posted. And I'm thinking about doing something about the economy, how we can get some financial people that can help us, how to prepare for the recovery, because it is a big question mark, how we're going to get people to come back to work and to have the patients coming back to have treatment. So thank you for Stroman, and I am more than open to hear your questions. Thank you.